So please start the class, sir.
Shall I start?
Yes, sir. And adjust your camera, sir, please.
Okay, is it okay?
Yes, sir.
Okay. Okay, students. Today I'll be starting renal system, and in renal system is one of the important chapters in medicine. There are a lot of questions are being asked, and so that this is the first chapter, first class on renal system. Okay. So in the renal system, I'll be starting with acute kidney injury. Acute kidney injury. Hold on a second. I'm just adjusting here. Okay. Acute kidney injury. So what is acute kidney injury? What is? It was we used to call it as even as acute renal failure when it goes into a stage. Of course, the injury means there is a injury that is a problem with the kidney due to it could be in whatever stage. It could be in early stage or it could be end up with there are staging with the criteria. So I'll come to that in later in the class. So here acute kidney injury means uh, it is impairment of kidney filtration and excretory function. Kidney is basically has got excretory functions of the toxic metabolites and they are to be excreted out. And if there is a falling short of it, and if it happens acutely, it should happen acutely, suddenly, within few days, like that, then we call it as acute kidney injury. And due to this failure of excretory functions, there is a retention of this nitrogenous waste products in the body. And this will cause problems for the body. And also there is a fluid retention. Fluid, apart from this, there is a fluid retention, acid base imbalance. So many things will there. Even endocrine problems also can set up. Okay. That's about acute stage here. That's about definition of acute kidney injury. Now, how acute kidney injury manifests? Acute kidney, how it is manifesting? Okay. So here, just hold on. This window is causing a lot of problem. Okay, but yeah. So here it is. When acute kidney injury starts in the stages, I mean, so not stage. Here discussion is the etiology. Whether etiology was to begin with, whether it was a pre-renal, or to begin with it was renal, or it is post-renal. So case which is pre-renal in etiology can also develop renal problem later, and this post-renal etiology can also end up with the intrinsic problem. So if the disease itself is intrinsic to the kidney, then it is stays in situ there. So pre-renal means the kidney has got a blood supply and it depends upon the blood to enter the kidney. This is the kidney, and these are the ureters. So diseases which occur before entering the kidney are pre-renal. Diseases which occur inside the kidney disease are renal, and the diseases which are secondary to the ureter obstruction or bladder or urethral obstruction, urethral obstruction, they are called as post-renal diseases. Of course, this pre-renal doesn't mean that it doesn't induce intrinsic renal disease. It supplies even to this. Post-renal disease can also develop intrinsic kidney disease over a span of time, or if it is not treated, it can end up with intrinsic liver kidney disease. So what are the pre-renal causes? Pre-renal causes here, as the most important one is hypovolemia. This is what you see, and the most commonly what we see is acute gastroenteritis causing, how many of you must have seen this? Pre-renal causes are acute gastroenteritis causing dehydration, leading to hypovolemia, leading to AKI, acute kidney injury. And acute kidney injury, you should also know that it can supersede on chronic kidney disease. Acute kidney injury can supersede on chronic kidney disease. In fact, a patient who is having chronic kidney disease are more likely to develop superadded AKI because their kidney is vulnerable. So they are most prone likely to develop kidney injury whenever they are subjected to any of these problems like hypovolemia and decreased cardiac output. That means heart failure, heart failure, and decreased effective circulating volume. Similarly, congestive heart failure, even renal failure. What happens is there's a fluid accumulation in the third space. The not intravascular fluid is less here. In liver failure patients, the intravascular fluid is less, but of course the body may contain a lot of fluids, but the intravascular fluid being less, it produces AKI because of that. It is a complex problem. Although the patient has got a lot of fluid in his body, could have been accumulated in the ascites, in the fluid abdominal cavity, but the intravascular volume will be less there. So that will be the cause for this acute kidney injury. It is also called as hepatorenal syndrome. So liver failure with AKI, liver failure with the kidney injury are called as hepatorenal syndrome. There are types of hepatorenal syndrome that we will be dealing in when you deal with hepatology, but you should know that liver failure, the intravascular volume is less. Although the body fluid status is more, it can be there. And even this impaired renal autoregulation. This I'll show that. So got some diagrams on this later. How this NSAIDs, these inhibit prostaglandins. So when they are inhibited, so the afferent arterial vasodilation, afferent arterioles, hold on, what I mean, I will show the glomerulus here. Suppose this is a glomerulus. The afferent arterioles come here, they form a mesh here, mesh, and afferent arterioles get out like this. These are afferent arterioles, these are afferent arterioles. So this is a glomerulus, and here glomerular filtration happens here. Filtration happens. Now, for this filtration to happen, there should be sufficient hydrostatic pressure. Is a predominant pressure, of course, osmotic pressure and all that they are there, but the major driving factor for glomerular filtration is hydrostatic pressure. For hydrostatic pressure, there should be sufficient flow of blood, and the outflow of blood should be checked properly. So if these should be vasodilated or not completely, at least there should be sufficient blood should be sufficient dilated. Afferent artery should be dilated and afferent artery should be constricted in a case of emergency, I'm telling. So in a case of emergency, if the person is taking NSAIDs, or if, for example, a patient has got developed hypovolemia, suppose, so imagine. Now in such a case, the afferent arterioles have to dilate and afferent arterioles have to constrict, thus that the CFR will be maintained. If there is a problem here, if there is a problem afferent and afferent, NSAIDs will act on prostaglandins, and ACE and ARB, these are antihypertensives, will affect on afferent arterioles. These should there is a angiotensin 2 receptor here, which when stimulated will cause vasoconstriction. If you give these receptor blockers, this vasoconstriction will not happen. The afferents will dilate and afferents will not dilate. So in effect, there is hydrostatic pressure is reduced. So thus I got few more diagrams when I go to the next slides. NSAIDs and ARBs can, in a patient who has got hypovolemias, if you give these drugs, they may develop pre-renal azotemia, and similarly cyclosporin. Now, intrinsic. Now, after the pre-renal, we'll go to discuss something about intrinsic kidney diseases. Glomerular, acute glomerular diseases, glomerulonephritis, you know that they are all there. Then tubular interstitial diseases like analgesic nephropathies can also cause kidney disease. And vasculitis, this is a TTPS, inoscolin purpura, their vasculitis, they also can cause intrinsic renal disease. This intrinsic renal disease, further due to this vascular disease, can have ischemia. They also can develop sepsis. And these intrinsic disease can also be due to these contrasts. We use contrast here. That these I'll discuss this contrast induced AKI. I got slides on that. This contrast will also cause intrinsic renal disease, amphotericin, proton pump inhibitors, NSAIDs, hemolysis, rhabdomyolysis is one of the important causes of renal AKI is rhabdomyolysis, myeloma. Myeloma proteins, they're secreted in the GFR. They end up plugging the tubules and thus cause renal failure, AKI. Intratubular crystals. This is how this can cause intrinsic AKI. And after this intrinsic, there is a post-renal. Here in post-renal, the obstructions, what we talk about this obstruction means, what are the obstructions here, students? Post-renal obstruction could be in the ureter, or it could be in the urethra, like a prostate, stone here, or stricture, and all these things can cause post-renal AKI. Post-renal AKI. So any doubts till now? Students, are you there?
Yes, sir. No doubt, sir.
Okay. So just tell me then how NSAIDs will worsen the hypovolemia status. Anybody can answer that? I told you that NSAIDs will block.
It will not.
Because they will not allow the vasodilatation of the afferent arterioles. By preventing the vasodilatation of the afferent arterioles, the effective blood flow into the glomerulus will be not there. This happens more so in a patient who has got hypovolemia. And you should always know that analgesic nephropathy is different from hypovolemia worsening of NSAID. This is different. There is something called as analgesic. What is this? Analgesic interstitial nephritis or analgesic nephropathy is a different disease. What I am discussing here it is NSAIDs induced afferent arteriolar block. I mean prevention of vasodilatation. This is in the context with the pre-renal and interstitial nephritis. Where is it? Here. I think it should be here somewhere. Yeah, here it comes. Interstitial nephritis and post-renal is this group of drugs, this group of diseases. Okay, now we'll go more into the pre-renal azotemia. And as you can expect, it is a most common cause of AKI, that is acute kidney injury. And it usually due to inadequate renal flow and intraglomerular hydrostatic pressure. That's what. The most important thing is this. Intraglomerular, I showed the diagram here, intraglomerular hydrostatic pressure. It has to be maintained to produce GFR. To produce GFR, it has to be maintained. The causes are, as I told you, azotemia, hypovolemia, cardiac output decrease, these medications, and I discussed this also. Afferent vasoconstriction is required to maintain the hydrostatic pressure. Afferent vasodilatation is required to maintain the glomerular perfusion. If there is a failure in this, there will cause renal azotemia will happen. Autoregulation and see there is a feedback depending upon the type of the filtrate that comes. There is a feedback. There is always a feedback. Hold on. Okay. There is a feedback. So this feedback will take care of the vasodilatation and the vasoconstriction of the glomerular afferent and efferent arterioles, because this tubulo-globular feedback is there. And if there is a failure in this feedback, then there is a worsening of renal azotemia also happens. And in this diagram, I have shown you here, that there is a what is this? There is a normal, how the glomerulus will maintain its flow. This is afferent arteriole here. There is a afferent arteriole here, and this is a efferent arteriole. They are to be, this lumen size has to be balanced according to the volume of the fluid. Thus that the amount of hydrostatic pressure is maintained so that GFR happens. That's a one thing you should keep in mind. And if there is a problem with this, like a decreased perfusion pressure, this will happen when the reduced perfusion pressure happens when the normal glomerular pressure is maintained by afferent vasodilatation and afferent vasoconstriction. Same thing, yeah. Increased vasodilatry, this is what same diagram. I mean, if there is a prostaglandin here, which are responsible in afferents, and ACE receptors are important in efferents. So, prostaglandin are with respect to afferent arterioles. Prostaglandins are for afferent, whereas ACE receptors are for efferent. So this is how the hydrostatic pressure is balanced. Very important, like that. Now, so decreased perfusion pressure in presence of NSAIDs. How it happens? It is because of, tell me. So decrease in perfusion pressure, it happens because loss of vasodilatry of prostaglandins increases the afferent resistance. So when the afferent resistance happens, if these are blocked, the pressure inside here falls down. That's what they're telling. Because by giving NSAIDs, you are blocking the prostaglandins. So there is no vasodilatation. So the pressure after the afferent arterioles falls down. And the decrease in presence of ACE, it is efferent vasodilatation. The ARB and ACEs, ARB and ACE receptors will block the receptor, and efferent vasoconstriction will not happen. Thus, the hydrostatic pressure here will fall down. Now, after that, pre-renal will go to the intrinsic one, and intrinsic, there are more of systemic causes. The systemic causes are sepsis, ischemia, and nephrotoxins. So this is the same thing which has got a diagram. Just to memorize your physiology, I put this here. So here there is a cortical glomerular nephron, and this is a juxtacortical glomerulus here, nephron. And here the intrinsic could be due to the glomerular nephritis, vascular, then this TTP and DICs, and all the causes will lead to AKI, secondary to intrinsic disease. You should remember this DIC, one of the common causes which we'll see in presence in patients with in whom we'll see in a patient who are suffering from sepsis. They may develop DIC, and they can develop this AKI. And apart from that, the ATN, what is acute tubular necrosis? If the patients who has got a pre-renal problem, if they're not treated, later on they will end up developing what? They end up developing AKI. So ATN, sorry, they develop toxic ATN. Even in sepsis they can develop endogenous rhabdomyolysis. They'll plug the tubules, and thus they can develop intrinsic renal failure. And this contrast nephropathy, this also can produce intrinsic renal failure. And sepsis, I told you already, this sepsis it will develop DIC, and also directly it can cause damage to the nephron. Intra tubular multiple myeloma. See, multiple myeloma, there is a lot of gamma globulins. These will get secreted into the nephrons here. From the globulus, they end up end up here, the tubules. They can plug this and cause intrinsic renal failure, multiple myeloma. And these drugs, acyclovir, are toxic. They can also develop acute renal failure secondary to intrinsic kidney disease. And this allergic to PPIs, NSCIDs, these the infections, this pyelonephritis can also. Then we have got infiltration. So these are all inflammatory diseases like Sjogren syndrome also can cause intrinsic kidney disease. Now, this is the one thing which we see a lot in medical. It is all iatrogenic. Iatrogenic AKI. We see many a times. Even in our cath lab, we sometimes end up with the iatrogenic AKI. Even in radiology department, they do give a lot of contrast to get image. So these iodinated contrast can cause ATN. Sorry, AKI. Can cause AKI. So iodinated contrast here, what happens when you give iodinated contrast, the serum creatinine start increasing after 24 to 48 hours. Usually it peaks by 3 to 5 days, and within 1 week or something like that, the patient settles down. Rarely they may require dialysis. Usually they don't require dialysis. Most often they heal by themselves. Of course, if they have got underlying already chronic kidney disease and you are given contrast because the investigation was required, or if the patient underlies CCF, if the kidney is having already compromised state, if you give contrast, the chances of they developing AKI is more. They are more, and also the prognosis is bit hard. The patient may require dialysis to recover. The mechanism of contrast induced renal failure is hypoxia in the renal outer medulla due to perturbations in the renal microcirculation and occlusion of the small vessels. So there is a microcirculation. There is a variation in its flow. Due to this varied flow, the outer medulla, there is hypoxia, and the patients will, and because one thing you should know, the supply to the kidney blood happens from inside out. The renal artery comes here, and the cortex is the outermost. The blood supply goes like this. So it is almost like at the end. If there is any compromised state happens, if there is hypovolemia, suppose, if there is a CCF, suppose, so these are the marginalized tissue. Already they have got they are the periphery. So if there is any problem, these will suffer the most. This cortex, because of that, they suffer the most. So this hypoxia will manifest there more severely, and thus the contrast-induced nephropathy happens. Cytotoxic damage of the tubules also happens due to the contrast. It is a cytotoxic, and it can damage the kidneys by generation of these oxygen-free radicals, and transient tubal obstruction with the precipitated contrast material. So the contrast material is thicker. It is not very liquid. It is more like an plasma like. It is bit thicker. So if you have got a thick fluid, it can get precipitated in the tubules, and of course it may precipitate and cause obstruction of the tubules. Thus the contrast will cause acute kidney injury. And always, that's why when you are sending the patients for contrast studies, the more often we always check for what do you say, renal functions before. Then we subject the patient for contrast study. Could be brain, heart, wherever. Iodinated contrast. If you are giving, always check for renal condition and then proceed. Post-renal AKI, I already told you, because urinary flow is unidirectional. If there's a block, there's a retrograde, the pressure buildup, and this can cause renal failure. Hydrostatic pressure buildup is there in the retrograde fashion, and thus there is a decrease interference with the glomerular filtration and causing AKI, acute kidney injury. Same thing, the problems where the block can happen, the stones can be there, compression of by the any tumors. There could be a tumor which is sitting and compressing the ureter, and retroperitoneal fibrosis which is compressing here and cause postrenal prostatic enlargement here, and it will obstruct the prostatic urethra, and strictures in the urethra can also cause acute kidney injury or sudden acute and chronic like. So now before going into the diagnostic evaluation of acute kidney injury, let us know how these patients will come. The patients usually have oliguric phase, and after that during recovery they develop polyuria. So whenever the acute kidney injury happens, more often there is of course non-oliguric renal failure is there. The most common is oliguric renal failure, where the kidney will not excrete waste products as well as water. So the urine output will come down. During the oliguric phase, the patients will develop hyperkalemia, acidosis, that is metabolic acidosis. Then they can develop hypocalcemia, usually hyper phosphatemia. These are things that develop, and pH will come down. pH will come down. This is the oliguric phase. So in follow that during recovery phase or whatever, the patient's polyuric phase, the patients will excrete around 3 liters per day urine. They excrete a lot of urine, and the patients may develop dehydration due to because of polyuria. So volume has to be replaced. Most often it is crystallite are given, and the patient may develop electrolyte imbalance, like the patients may develop here hypokalemia. There in a oliguric phase, the patient had hyperkalemia, whereas in a diuretic phase, the patient develop what? Hypokalemia, and acidosis will recover here. And the hyponatremia also may happen, and hyponatremia can cause convulsions. That also can happen. So in a patient who is in diuretic phase of acute renal failure, you need to check all these parameters and keep treating them. Okay, keep treating them. Now, urinary protein. Now, what are the laboratory tests you do for a patient with the AKI? What all laboratory tests you want to do? Students? Hello?
Urine output, serum creatinines.
Yeah. The one thing that
albumin.
Tell me.
Albumin and other excretory products, sir.
Albumin and?
Which may suggestive of sepsis or
albumin
and other RFTs, sir. Because of glomerulonephritis.
No, I am not specifying to glomerulonephritis. We are discussing acute kidney injury or acute renal failure. Let us focus in this fashion. So, if you are diagnosing patients with acute kidney injury, you want to look for urine output. That is important because the urine output is a very important prognostic factor. The lot of urine output is fallen down means or oliguria. If it is anuria means very bad. Very bad it is. That's why the urine output, as you said, the monitoring of the urine output is very much important when you are dealing with acute renal failure. And depending upon the urinary findings, we can diagnose the etiology for acute renal failure. Why he developed into acute, why patient developed acute kidney injury. You can look into that. So the AKI from ischemia, that is ischemia or nephrotoxin, leads to less proteinuria. If the proteinuria is less than 1 gram per day, then probably some hypovolemia, ischemia, and nephrotoxins are the causes for AKI. And if a lot of proteinuria is there, more than this, and of course less than this, less than 33.5 nephrotic syndrome, then if the proteinuria is in this range, then we can think of damage to the glomerular apparatus, glomerular membrane damage is there. That's why proteinuria is happening. That's what it suggests. And if the uh, multiple myeloma is there, these light chains will not be picked up with a dip test. What they do is urine dip test to check for albumin. It will not be picked up. This will not pick up myeloma proteins, Ben John's protein, whatever. They are not picked up with your dip test, sticks test. Dip stick test is not picked up by that. So you'll have to do a special test only. So that test will be negative in a patient who has got a myeloma, multiple myeloma. Dip stick test will be negative because they'll be excreting light chains, globulins, which are not picked up by this diptyque test which you use. They have to do a separate test only. And atherosclerosis can also cause variable degree of. So see, there are some procedures. The procedures are the patients will embolize the atherosclerosis plaque in the vessels. For example, aorta has got a descending aorta has got a atherosclerotic plaque. Imagine this is a descending aorta and a renal artery is coming here. This is a descending aorta. Renal artery is coming here out. So if there's a plaque somewhere here, or could be plaque here only, plaque here. This can embolize and go into the kidney and plug this small vessels here and cause AKI. Especially it happens when you are doing some procedures. It is more likely to happen. So this atherosclerosis can also cause AKI like that. Atherosclerosis causes AKI because of that, and they will develop a variable degree of proteinuria. It could be less than 1 or more than 1, but more often it is more than 1 anyway. And as you are telling the nephrotic range, if you got a proteinuria which is very high, more than 3.5 grams per day, then you should suspect nephrotic syndrome or tubulointerstitial disease caused by NSAIDs. NSAIDs. Okay. Urine in AKI. Prerenal acidemia may be present with hylia. So there are type of casts which are present, which manifest with the different AKIs. For example, in prerenal, there are hyaline casts are there, and in post-renal, there are unremarkable segmental there. ATN or a renal, we can get a muddy brown. We cannot see this is a prerenal is hyaline cast. Post-renal it is variable. There are no specific. You may get hematuria because ureter is being damaged or urethra is damaged because of the stone. That's why hematuria can be there. Or if it is an infection and of the infection of the ureter or urethra, pyuria may be seen. But if it is an intrinsic renal disease, then muddy brown casts are seen. Muddy brown granular casts are seen. Interstitial nephritis, white blood cell casts are seen. These are some important type of the casts. There are many more casts in the kidney disease. I had only picked up the important ones which are more commonly discussed in MCQs. So hyaline cast, prerenal. ATN or intrinsic kidney disease, muddy brown. Interstitial nephritis, white blood cell cast. And post-renal is hematuria and pyuria. Try to memorize them. The MCQs can come around that. Kidney biopsy. Now, if the cause of the AKI is not apparent, so the kidney biopsy is rarely done in a patient with the acute kidney injury. It is usually for chronic diseases, because if you are not able to find out the cause for his renal failure, acute, then you may think of doing a kidney biopsy. Kidney biopsy is better avoided because it has got a lot of possible complications. So we only do it when it is mandatory. So in the context of AKI, kidney biopsy is rarely done. But however, for discussion, when it can be done, when you don't know the cause, you have tried all the plausible investigations, you have taken a good history, still you don't know the cause of acute renal failure, then you can think of doing kidney biopsy. And of course, if you are suspecting these diseases, then you can think. Then these two commonly investigated blood parameters, blood urea nitrogen and serum creatinine, for they will assess only GFR. GFR, glomerular filtration rate. Glomerular filtration rate, because they are not absorbed in the tube. They are neither absorbed. Why they are used? These are neither absorbed or excreted in the tubules. So they are, whatever is if they are increased in the uh, blood, means it is not filtrated. That's all it suggests. It doesn't tell us anything more. Okay, one express serum creatinine. So it only suggests decrease GFR. But with this alone, we cannot pick up the amount of damage to the kidney. Amount of damage to the kidney cannot be assessed with this. I'm not telling clinical picture. I'm talking about amount of kidney damage. To diagnose the amount of kidney damage, or to know the severity of the AKI, there are other tests also there. So one of the most commonly used test is give a challenge with IV furosemide 1 to 1.5 mg per kg, and if the urine output is less than 200 ml in the next 2 hours after intravenous furosemide, patient has got high risk of progression to more severe AKI. So if you have got a patient of AKI, you do this test, and if it doesn't secrete urine, at least 200 ml, then the chances are this patient can go into severe form, and better be prepared to handle the serious case as a serious case. It is early way to pick up, so that you may even think of sending him for him to a center where dialysis or a nephrologist facility is there. That's the reason you got to assess the AKI severity. And urine microscopy and severity of AKI. Can you pick up anything in that? Greater number of renal tubular epithelial cells, or granular cast in the urine sediment is associated with both severity and worsening of AKI. If you got a lot of granular cast, a lot of renal tubular epithelial cells are present in the urine microscope, are present, then the amount of damage is more likely to be high. Then let him go to higher center for further treatment. Don't take chance with these patients. Then there are some novel protein. A lot of MCQs are being asked on these novel proteins. You should know them. So the novel protein biomarkers to assess the amount of kidney injury. Just see this amount of kidney injury. Kidney injury molecule Kim1, Kim, North Korea, Kim1. Then other one is NGAL. These two are more commonly used, and this one is approved by USA. Approved in USA. This is a insulin like growth factor, and this is wrong. So TIMP2 and IGFPB7. These can be assessed to study the amount of kidney injury. They can ask which of them following is not a biomarker of a kidney injury. Like that question can come. Just know these things. I'll come to one. I'll discuss one by one in the next slide. Kidney injury molecule Kim1 is a type 1 transmembrane protein in the proximal tubule cells. It is injured by ischemia. Know this. It is ischemia, whereas NGL is inflammation. Injured by ischemia or nephrotoxin such as cisplatin. Functions. It basically this what is kidney injury? It will phagocytis properties of tubular cells. It actually clears debris, the protein debris, whatever comes falls now. This molecule will see to it that this is done, because it clears the kidney like that, inside the kidney debris, reduce the inflammatory response to the acute injury. This what this does. And this neutrophil gelatinase associated NGAL is also known as lipocalin 2 or pseudocalin. This was actually discovered in patient in human neutrophils initially, but however its role in the kidneys also is known now. It binds with the iron. Tissue protective effects are there. It has got a tissue protective effects, and that is because it gets upregulated during the inflammation. Whenever there is inflammation in the kidney, this NGAL will get upregulated and detected in the plasma and urine within 2 hours. Yeah, see, whenever CABG is done, CABG is done, there could be hypotension, decreased circulation can happen, and this will cause AKI, and it is known to increase within 2 hours if there's a kidney injury. Now, what are the complications of AKI? So, the uremia, hypervolemia or hypovolemia, depending upon how the patient is being managed. Hyponatremia, I told you how it happens. Hyperkalemia, acidosis, hyperphosphatemia, hypocalcemia. They can ask you which of the following is not a renal failure cause, like that. There are some questions like that. That's why. Cardiac complications, like patient may develop arrhythmias, pericardial rub, pericardial effusion. They can develop malnutrition, anemia. They may develop. And uremia, the signs of uremia signs are astraxis, and coma. All these things, uremia signs can be there. Hypervolemia, the patient may develop. Hypervolemia means pulmonary congestion, pulmonary edema. Otherwise, they can develop. Hypovolemia means shock. They can develop. Then hyponatremia means it could be dilutional hyponatremia can happen, and hyperkalemia because potassium is retained. Acidosis because the acid is also retained here. Hyperphosphatemia and hypercalcemia, also bleeding. Yeah, hematological complications also will happen. The thrombosis and a clotting mechanism will be disrupted in a patient with the AKI, so thus there is a bleeding chance. These are the complications of AKI. Prevention and treatment of AKI. The treatment of AKI goes with the in the different stages I'm discussing here. The one is pre-renal, how to treat. Then if the patient develops a cirrhosis or hepatorenal syndrome, how to treat. Intrinsic, post-renal, and supportive. We'll go with each heading. So in a patient who has got pre-renal azotemia, now the patient has not developed intrinsic kidney disease in the early stage. How to treat? The wisest way would be to replacement of the fluids. The type of the fluid replacement depends upon what is lost. Blood is lost, replaced with the RBC packed cells. And if there are a loss of plasma, then what you want to give? Students?
Ringer lactates.
Crystallites or colloids. Okay. Crystallites or colloids. I'm talking about plasma. Avoid albumin. Albumin, don't give albumin unnecessarily. Here. Of course, if the patient has got hepatorenal syndrome, albumin is given, but otherwise, that's why hepatorenal syndrome, there is a separate topic given there. And if you are giving only saline, which has got chloride, you should know that patient can develop hyperkalemic metabolic acidosis. So, give bicarbonate, sodium bicarbonate solution. Sodium bicarbonate instead of NaCl solution, patient should be receive sodium bicarbonate solution here. That is better. So what are the crystallites? Best is NS. And if the patient has got hypernatremia, then give hypotonic saline. Hyponatremia means give hypotonic saline. Depending upon the electrolyte problem, you have to correct it. And the replacement has to be properly, carefully planned and done. Albumin is not indicated in a pre-renal azotemia, but it is indicated in a patient who has got this albumin. If patients of cirrhotic who has got a lot of a third space accumulation of fluid, if they develop renal failure, then the albumin is a better choice here, rather just giving sodium NaCl. Albumin is better choice. Of course, if they develop hepatorenal syndrome, liver transplant is a correct treatment. Of course, you can give these drugs till the patient undergoes for liver transplantation. They can be maintained with this. Giving this as a cocktail. They given as a cocktail here. Hold on. They given a cocktail here. This cocktail you can use. Okay. The cocktail is vasopressin. Then you got octreotide, Midorone. These cocktail can be given as a bridge for liver transplantation. So the hepatorenal syndrome, this is just a temporary, and more often they will have spontaneous bacterial peritonitis. This is cirrhotic with hepatorenal syndrome. What is spontaneous bacterial peritonitis? Anybody can tell me, students? So the peritoneal fluid will get infected with bacteria without active intervention. Nobody has, there is no rupture of the bowel, or nobody has pushed anything inside the peritoneal cavity. Spontaneously, patients will develop acidic fluid infection. This is because there is a decreased protein here in the body. Decreased protein means decreased opsonization. Opsonization. So decreased opsonization means the bacteria can invade. That's the reason these patients are prone to develop acidic fluid inflammation. And acidic fluid inflammation, peritoneal inflammation, they develop this hepatorenal syndrome. So the albumin is less, so the treatment would be to the crux of the beginning of the problem is albumin. So replace that and treat them hepatorenal syndrome. Intrinsic AKI. The intrinsic AKI, no specific treatment. Whatever is the cause, treat that. That's it. And there is hypervolemia or hypovolemia. Depending upon that, you have to decide about the diuretics. And post-renal, it is a relieve the obstruction. And you should know when the patient requires dialysis. A patient who has got acute renal failure, the most important thing to keep in mind is when the dialysis is required. When the dialysis is required. So the dialysis requirement is when you medical management is failed, and in spite of all your medical diuretics, intravenous soda bicarb, all you have tried, still the patient persistently has got hyperkalemia and has got acidosis and volume overload. These things are persistent, then the patient is better dialyzed, and these things are controlled like that. And if there is a clinically, these things are the asterix is there, pericardial or effusion is there, encephalopathy, uremic bleeding, any of these are there, then their patient needs dialysis. And some nephrologists even take this blood urine nitrogen more than this much. This is a more aggressive approach. This criteria, the last one which I put it here, the more than 100 milligrams per DL, if there is a burn is there, some patients burn is usually, it comes to around 50% of blood urea by calculation. You should know that. So 100 mg means 200 2.5 our serum or blood urea. 200 means it will come to 100. More or less, the calculation goes like that. Nearby that. Now that's about theory of acute kidney injury. So students, any one of you want to ask any doubts? Tell me now. We'll go to what? What shall we go? MCQs now. So the first MCQ. Who wants to answer? This is a very simple question. Students. Hello? Manjunath?
50 mLs.
40. It is 40. It is 40 ml. This is a straightforward question. It is a 40 ml. I'll go to this question. Hold on here. It is polyuria means more than 40 ml. And you should also, along with that, I just given this polydipsia means more than 100 ml. Which of the following parameters used to identify tubular damage in KIDCO criteria versus referral? Huh? Referral criteria. Which of them is used? Kidney damage. Which of them is which suggests does urinary stadium or kidney damage?
NGALs.
Good, thank you. Whatever criteria, whatever, that is the one thing which has been used. NGL. Now let us know these criteria a bit. They can ask some questions on these criteria. Okay. This is a refill criteria and KIDCO criteria for this one. And here they're all basically, and this see here this refill has got a lot many stages right up to kidney disease, whereas these two have, these are only 3, 1 2 3 1 2 3. And one thing which is common here is increase serum creatinine 1.5 and decrease or GFR decrease more than 25%. Here increase serum creatinine 0.3 ml per DL within 48 hours. Okay, or increase in serum creatinine 1.5 times. See, both 1.5 times serum creatinine. Stage 1 is 1.5 here. This is 2. Serum creatinine more than 2. Here the stages is also say 2 to 2.9. It is 3. So more or less the easiest way to remember this up to 1 to 3 is 1.5, 2 and 3. If it is 1.5 to 2 na, then it is a stage 1. 2 means a stage 2. 3 means a stage 3. Okay. Creatine wise. Creatine wise. Here apart from that, this KIDCO score also has got urine output. Urine output. The table why I did not put here. There is a even along with this you can use urine output here. I'll put that to give the table later. There is a even along with the creatine level there is a urine output. That's what here is there here. Now here apart from these risk, injury, failure, the third is fourth one is loss, kidney loss and kidney end stage kidney disease. So persistent renal failure complete more than 4 weeks here, more than 3 months. If the renal failure is persistent, more than 4 weeks is loss, and if it is persistent more than 3 months, then it is end stage kidney disease. So these are the criteria: risk, injury, failure, loss, end stage kidney disease. It has got a 5 stages. End stage kidney, if they ask you acute kidney disease, when you say it is a end stage means more than 3 months renal failure. Persistent means then you can tell it is a patient has got a persistent renal failure. That's what it means. Okay. Okay. MCQ. Read the MCQ. Students, if you don't want to answer, you can even put it in a chat box. Okay. So 70-year-old diabetic hypertension patient was being investigated for angina. So this is a 70-year-old man, he is a diabetic and hypertensive. So he is investigated for angina and a coronary angiogram was performed. 2 days later, he developed fever now. So this is a diabetic hypertensive patient. After 2 days, he developed fever, abdominal discomfort, dyspnea, and motile skin rash. He appeared black. His BP increased to 180/100. His creatinine was found to have raised from pre-angiography level to 1.5 to 3.6 per DL. He has eosinophilia. Which one of the following statement is true about regarding this condition? So N-acetylcysteine would have prevented this condition. When you use N-acetylcysteine, where all you use N-acetylcysteine, students?
Paracetamol poisonings. Paracetamol poisoning.
Fantastic. Then in patients who are, whenever we give angiogram, now whenever we do angiogram, we are concerned. Sometimes it is not a proven therapy. It is not a proven therapy. If we are concerned that patient may develop kidney damage, usually we give it later. We give this in SR16. Anyway, it is not effective. It won't prevent it. Kidney damage. This is empirically designed therapy, but anyway, contrast-induced nephropathy is not much benefited with this drug. Anyway, still it is a practice to give, but okay. This is contrast-induced nephropathy. Do you agree with this? Students, heparin is a treatment of choice. Kidney biopsy will show macrocell. Kidney biopsy will show. This is coming here. I am keeping these chat boxes open. That's why suddenly I lose this screen. Okay. Kidney biopsy will show microvessel. It is microvessel occlusion with the cleft in the vessels. Tell me now, which of the what is your answers? You can type if you want. Beryllium, Manjunath, Smriti. Now he is telling
only
you,
one answer, many.
Students, yes, tell me.
Is there only one answer or many answers?
One answer.
Only one answer or many answers?
One.
Second.
Second one. So you want to go for contrast-induced nephropathy. But how are you going to answer this eosinophilia? See, eosinophilia is there means it is atherosclerotic embolization. I told you actually just now. I said it, you did not pick it up probably. Atherosclerotic embolization will cause eosinophilia. Will cause eosinophilia. That is this one you should pick it up. So this kidney biopsy will show microvascularitis, occlusion with the cleft. That means atherosclerotic embolization will go, and this emboli will go and plug the microvessels and cause AKI, and they will have eosinophilia there. That is the answer. Beryllium says it is A. Okay. Now I would go for this is the answer, kidney biopsy. I'll show you that. That is the one thing. This is a trick here. You have to look at here in this. And these patients, of course, coronary angiograms usually, okay, angiograms can cause, and there's a shot up in the BP and go down here. And his creatinine was found to have raised from per DL. And usually this contrast-induced nephropathy developed after 48 hours. 2 days later, developed fever, abdominal discomfort, dyspnea, motile skin rash. These all are not signs of what is this contrast-induced nephropathy. Skin rash. Hello? Motile skin rash will not happen with the contrast-induced nephropathy. These all points towards atheroembolization. Yes, anything? 50-year-old patient develops a cardiogenic shock. What Smriti she is marking? Okay. So 50-year-old patient develops a diagnostic 50-year-old patient develops 50-year-old patient develops a cardiogenic shock with a myocardial infarction. Okay. His urine output decreases in next few days. He has increased serum urea and creatinine. Urine analysis reveals no glucose or protein. But numerous hyaline casts are present. After few days, he develops polyuria and serum creatinine level falls. Histobiopsy of this patient will reveal human complex, glomerular crescents, patchy tubular necrosis, mesangial deposits. What do you think? It is very straightforward, but See, what do you expect the patient to have a cardiogenic shock to develop? Do you expect him to develop immune complex disease?
Patchy tubular necrosis.
Yeah, that's correct.
Ischemia.
Yeah, these are all glomerulonephritis, na immune complex, glomerular crescents, RPG, and will this later class will decide this. And patchy tubular necrosis means ATN, acute tubular necrosis. This is the correct answer. Fine. You're seeing the screen, na students? Students,
Yes, sir.
hello? Okay, the next question. Morphological features of ATN, what are there? Just if you want to learn morphological features, focal tubular necrosis with a multiple line along the nephron, large skip areas in between, rupture of basement membrane. If they do biopsy in a patient who has got a acute tubular necrosis, this will be seen. And these TAMPs or false proteins can be seen there. A 40-year-old with a diazepam and alcohol overdose. 42-year-old patient has got a diazepam and alcohol overdoses. She is comatose actually. The patient is comatose now. Temperature is 34.5 degrees centigrade. What is the normal body temperature?
37.6.
34.5 means? What do you think? Hyper, hypo, normal?
Hypo.
Yeah, I want to tell that hypo. They are typing anything? So this patient has developed a hypothermia. Hypothermia is there. His BP is normal, but BP is normal. Creatinine is 2.4. It is more. AST is 500. GGT is 35. Urine dipstick test showed 3 plus blood urea. But otherwise urine analysis is normal. That means there are no casts, nothing is there, normal. USG abdomen is also normal. What is the most likely diagnosis? Hypothermia, alcohol intoxication hallucinations, rhabdomyolysis, acute interstitial nephritis. Students,
Rhabdomyolysis.
why you want to go for rhabdomyolysis? Fourth one, acute interstitial nephritis. Beryllium says it is a fourth one. So others, if you don't want to answer, you can type. I have got watch box, kept your this one side chat box. There's no issues. Suchit also says it is fourth one. And who else want to answer it? Smriti, take a guess. So in acute interstitial or tubular interstitial disease, what type of cast I told you? Students, white blood cells cast. Did I tell you? Students.
Yes, sir.
Yes.
Yes, sir.
So I told you the but dipstick 33 plus is there, but otherwise the microscope is normal. Casts are not seen. Now you want to take a guess?
So first,
Hypothermia. Yeah, that is actually hypothermia is there means it actually matches like that. But why you want to do all these things so that the hypothermia one temperature is there? I don't know why they given that choice. It is a foolish thing to give there. It doesn't require anything medical students to answer that. That choice is meaningless only. Anyway, hypothermia I can't say no because hypothermia is there. I don't think so. The reason why they given this question is for to make you know hypothermia is definitely hypothermia is there. Okay, I can't say no for you, but apply many more things what are there inside the question. These questions now what are given in books actually they are derived from the students. We don't, none of us have got access to the questions which have been asked. Whatever, sometimes that's why the choices appear ridiculous. Choices appear ridiculous. See, the temperature is hypothermia is there. If you say there is hypothermia, I have to say yes only. But the way the question I got it from the books, I am putting it here. But that may not be the reason they are asking you this question.
Sir,
Something.
drug interactions maybe.
Yeah,
Diazepam and
which
alcohol.
drug? With what?
Diazepam and alcohol.
Both of them will cause what? Diazepam will
Sedation.
get metabolized faster.
Sedation.
Hmm. See, these alcohol overdose can cause rhabdomyolysis. Even hypothermia also can cause. So the here one point which you should know is this is a proteinuria, but urine is normal means it is rhabdomyolysis. Proteinuria is there, but urine is normal. This protein is actually myoglobinuria. 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 That's the reason we get urine dip text more positive. Causes of rhabdomyolysis: traumatic crush injuries, muscle ischemia during vascular orthopedic surgery, alcohol intoxication. This patient has got, and prolonged immobility, exposure to hypothermia, exposure to hypothermia, and compression during coma or immobilization, prolonged seizure activity, excessive exercise, heat stroke, married hypothermia infections. These are the few causes for rhabdomyolysis, and this patient has got urinary things, everything normal. That's why the most often we clinicians or many more, we forget the report of urine. We always look into the blood. So if you look into the urine report properly, and if the report it has been normally properly reported, we can diagnose the cause of renal failure. Okay, looking at the type of the cast, what kind of cells are present, we can actually pick up the cause of renal failure. But it is underutilized, easily available. That's why it is underutilized, underinterpreted. Sorry, underinterpreted. Okay. Now, acute renal failure results in. Type the answer if you don't want to tell. I want everybody to type at least answer this question. It is not
Fourth.
difficult.
Fourth. Hypokalemic acidosis.
So Manjunath says it's hypokalemic. Suchit, what do you think? Beryllium. Manju, Suchit,
No, sir. Three.
third, Ninda.
Yes, sir. Three answer. Hypercalemic.
Acidosis.
Hyperkalemia acidosis. Hypo or hyper? Which one?
Hypokalemia.
So beryllium says 3. Smriti also says 4. Sujit
3,
4.
sir.
Who said? I am getting confused. Which one has a old question, new question? Forget it now. Okay. So it is hyperkalemic acidosis. It is a simple question, very simple question. You should not miss this. Actually, I will put some simple questions so that you people get interest. Purpose, I'll put something into suddenly one simple question. All of the following are the causes of acute renal failure, except
Snake bite.
Pyelonephritis.
then. So snake bite, will it cause renal failure? Okay, can it cause renal failure?
No. No, sir.
See, it can cause renal failure in many ways. It can cause a hematological problems and end up with renal failure. It can cause the local gangrene, this, that, bite site, that causing infection,
Vascular toxics. Vascular toxics.
Yeah, so many ways it can cause renal failure. But if it causes renal failure, will it cause acute or chronic? It causes acute only, na? It is not chronic anyway. It will be acute. So acute renal failure is possible in renal snake bite. This is not the answer. And pyelonephritis, can it cause acute renal failure?
No, sir. Chronic, no, sir.
Why not? Pyelonephritis cannot develop fast. It should be chronic only. It can develop acute. Rhabdomyolysis can also be acute. What is this analgesic nephropathy?
Sir, fourth one.
Just I told you,
NSAID induced.
CRDS, afferent arteriole is different, analgesic nephropathy is different. I told you 5 10, gave the diagram purposely for this question only. Keeping this question in future, I gave you that stress there. So analgesic nephropathy is a chronic problem more often. Acute interstitial nephritis is there, but analgesic nephropathy is a chronic interstitial nephropathy actually. It is a chronic disease. NSAID causing afferent arterial issues, that is not analgesic nephropathy. That is different. So when you diagnose a patient has got analgesic nephropathy, it is a tubulointerstitial disease. It is a tubulointerstitial disease, not a glomerular apparatus. It is not related to the tubules. What are tubules? Students, what is happened to this pen? Hold on. This pen is causing problem. So, okay. So analgesic nephropathy is a tubulointerstitial, not a disease of the glomerulonephritis. The disease is in here, not here. This is a apparatus. Analgesic nephropathy. So analgesic nephropathy is a chronic, not acute. Markers of a kidney injury are all except. So the last answer is given by beryllium. Anyway, I'll monitor it now. Which of them is the answer? It is alkaline phosphatase, not acid. This is the answer. Fine. So in renal failure, metabolic acidosis is due to. Students, why it is due to? What is the function of the kidney? Students, able to hear me or no?
Third one, sir. Third one.
What? Hello?
Excretions.
Yeah, the function of the kidney is excretion. Yeah, now the answer comes here. Beryllium has answered is 3 twice. Okay, the previous 3 and one more 3. Fine. So it is decrease excretion. So now let us go for this now. Increase hydrogen production. It is not an issue of renal problem. Production is not an issue here. Excretion is a problem. So this is not unlikely. 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 The loss of bicarbonate. That is not the one. Actually, the ammonia has to be excreted. It is not excreted. Due to that, decreased excretion of ammonia is a major reason for metabolic acidosis. Okay. Okay, that is the reason. Biomarkers not used in acute kidney injury is. I think so. I discussed this and this actually already. These two, and this is the answer. This is microRNA is not used here. Difference between sodium and chloride is low. The difference between sodium and chloride is low. The metabolic disorder in this patient is acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. The difference between sodium and chloride is no. What is anion gap? You sum the cations, sum the anions, and the difference between them. Actually, the difference between predominantly the an. See, what are the cations? It could be sodium, potassium, or the cations. The anions are SCO3 and chloride. Of course, there are many more. things here. These are another pool. You have to add this and this. Add this and this. So the value of a bicarbonate is around 20. Chloride will be something around 20, 96 to 100. And here sodium is around 137. Potassium is around 3.5. Bicarbonate is around 20, 25, something like that. Chloride is 96. So add this and add this. The difference is an anion gap. That means, yeah, they are putting it. Somebody said Manjunath high anion gap. Yeah, high anion gap. That is the answer. Metabolic acidosis is the answer. Okay. What happened to this pen? So the sodium and chloride, the value, that means the anion gap has what is the difference between not high anion gap, Manju, it is low anion gap. If you got the difference between the sodium and chloride is less, means it is a low anion gap. Anion gap is, sorry, not increased. Anion gap is not increased. That's what it suggests. When you got a sodium and chloride, the value difference is less, means anion gap is not increased. Otherwise, it is a hyperchloremic acidosis. That's what it says. Hyperchloremic, that means chloride has actually increased more often. So that's the reason here it is metabolic acidosis, what it suggests. So if the sodium and chloride values difference is less, it suggests hyperchloremic acidosis or decreased anion gap acidosis. Acidosis is not increased, don't call it decreased. The anion gap is not increased, at least. Otherwise, non-anion gap acidosis also we can call. So this is the right answer is this, metabolic. Worsening of kidney function and contrast nephropathy is best evaluated with. So which one among the two? This is the very best is creatine level.
High serum creatine.
Yeah, the creatine is very simple, and this is a simple question. Anuria is defined as, you do not put less than, the answer given is 4 ml. Answer given is 4 ml. Hepatorenal syndrome, urine shows proteinuria, hematuria, both, no abnormality. This, see, there is a proteinuria there as well as hematuria. As well as hematuria. Complication of diuretic phase of acute renal failure is
Increased sodium excretion in urine. Hyponatremia.
Yeah, they can cause hyponatremia. Sodium hyponatremia will be there in that because there is a loss of sodium loss. So they can develop even convulsions, that choice is there, but that is a rare thing. But the more common is hyponatremia. Okay, they can develop this also, but there is a rare because of hyponatremia, like that. But usually that doesn't happen. This is the correct answer. Increase sodium excretion in the urine. Investigation of oliguria in a patient revealed 800 milliliters osmoles per kg. Urinary sodium 10 milliosmoles per liter. Burn is 20:1. The most likely diagnosis is. Students.
Second one.
Pre-renal, acute tubular necrosis, acute cortical necrosis, urinary tract obstruction.
First one, sir. First one.
What?
One.
I'm not hearing. You can type otherwise. So this patient has got the one answer. Beryllium thinks it is one. Pre-renal. So this ratio is 20:1. 20:1. So the investigation of oliguria is there, and this one is high. And Urinary sodium is this ratio. I got a slide on this. I think so. Where is it? Yeah. Okay. Good. We'll discuss here on. Okay. See here. How to differentiate pre-renal, renal, and post-renal? Huh? What is that? Pre-renal or renal? Pre-renal azotemia means. Huh? So if the urinary osmolality is more than 500, in that case it is 800. See here 800. Hmm? Hmm? Then urinary sodium, like urinary sodium here. Urinary sodium is 10 millimoles per liter. It is less than 20. That means it this matches. Urinary, this matches. Then what is another thing they given here? Blood urine nitrogen creatinine ratio. That is more than 20. More than 20. So it is actually falling in between. It can be that side or this side like that. Okay, anyway, taking this, and also not letting this. So it is pre-renal. Pre-renal acute renal failure is a correct answer. Acute tubular necrosis means it becomes renal. Acute cortical ulcer becomes renal. Urinary tract obstruction means post-renal it will be. The post-renal will be it will be less than 400. It is where it is 800 in this case. And urinary sodium, and it is of course this also matches there 20. Because of milliosmoles 800 is there, the urinary osmolality is very high, so it is a case of pre-renal pre-renal problem. So the answer is, as you are told, it is first one. Differentiating factors between pre-renal and renal azotemia is sodium fractional excretion, creatinine clearance, serum creatinine level, urine specific gravity. Which one? Students? Tell me the answer now. Tell me the answer. Hold on. Hold on a second. Anyway, this is the last slide.
Third one, sir.
The differentiating by pre-renal is, in this case, what is the answer?
Third one, third.
Sodium fractional excretion. Did I have the slide here? Urinary sodium here. Urinary sodium and FeNA. So sodium fractional excretion is the correct answer here. So this is a table for that. So non-oliguric renal failure is commonly seen in students. Where you get non-oliguric renal failure? So you get in a drugs only actually. This is amino glucoside. So non-oliguric renal failure happens because of damage to the collecting ducts. So the concentration of the urine happens in the collecting ducts, and if that is at fault, the urine becomes, patients has got there will not be able to concentrate the urine, although there is renal failure, still there will not be oliguria. So non-oliguric renal failure is due to the damage to the drugs. This happens more often to the drugs like damage to tubules. More often it happens due to aminoglycoside induced renal failure. That's all for today. And if you want to ask any doubts, I can ask me now. Friends, any doubts? Thank you, sir. Fine. Okay then. Next class we'll go for chronic kidney disease. Thank you.